Hi, this is Bob Harrington from Stanford University. I have the privilege of being the chair of the Heart of Cardiology program for Medscape Cardiology and the Heart.org. We're going to cover really the breadth of cardiovascular medicine, some of the latest science, some of the latest insights into clinical medicine at the conference. And during this series of podcasts, we're going to be giving you a preview of the December meeting. Today, I'm really privileged to be joined by one of the country's leaders in preventive cardiology, Dr. Pam Morris. Pam is a professor of medicine at the Medical University of South Carolina, where she serves as the director of preventive cardiology. Pam, thanks for joining me here on this podcast.
Great. Thank you so much for having me. Really looking forward to the program.
Pam, the set of lectures I think that are going to be in this session, I think are some of the best that we're going to hear all week. And what I'd like to do is just walk through a series of things to get people really excited about the meeting. So let's start with maybe the obvious one. We've used statins for decades now. Clearly, we know that their effect is primarily mediated through the lowering of LDL cholesterol. What do you think about statins' effects beyond lipid lowering? We've talked about this for decades. Is this real? Is this hype? Is this anything that people should be thinking about for how to use statins? So, for example, Alan Brown's going to talk about statins in COVID patients.
Well, this remains an area of great controversy, I think. Thus far, it has been difficult to truly prove the hypothesis that statins have pleiotropic effects. In most instances, it really has appeared that most of the benefits really come from the LDL cholesterol lowering. But there have been some interesting observations, smaller observations about potential benefits in other diseases such as COVID-19. I don't think we have the answer to that yet. We had a recent study that was presented at the ACC annual meetings this year that suggested there wasn't really benefit to the addition of a statin in these patients. But certainly this is an area that is of great interest for ongoing study.
Well, let's take then the other side of the equation, which is statins obviously, as I said, exert their primary benefit through the lowering of LDL cholesterol. And we know with the guidelines from ACC and AHA that we're going lower and lower. Talk about some of the therapies beyond statin therapy for getting LDLs down into the targets we're looking for, whether they're under 100 for certain groups of patients, potentially under 50 or even lower for patients with advanced atherosclerotic disease. You want to talk about things like ezetimibe, PCSK9 inhibitors, newer agents?
Bob, you really hit a nerve with this question. I mean a nerve in a good way. So, when I started in preventive cardiology, and I won't tell you what year it was, but it was before statins. And we had nothing but the bile acid sequestrants for lowering of LDL cholesterol. And it could not be more fun than to be in preventive cardiology at a time where we have a literal explosion of therapies for prevention and specifically for lowering atherogenic lipoproteins. Certainly the long-awaited study of the IMPROVE-IT trial with ezetimibe has demonstrated, modest reduction with the use of a cholesterol absorption inhibitor, but they're really with our understanding of genomics, we've really begun to understand targets for lipid lowering with other non-statin medications. Bempedoic acid has been one of great interest, particularly for patients with statin intolerance, because this is a prodrug that is activated once it is ingested, and the enzyme that activates it is not present in muscle. So it makes bempedoic acid, although modest in terms of its LDL lowering, its potential benefits in patients with statin intolerance is great. And then the PCSK9 inhibitors, which have really revolutionized therapy, the monoclonal antibodies now FDA approved, and they've certainly been much easier in terms of access in recent years. They have good outcomes studies for cardiovascular benefits. And I think we can easily say that no matter what guideline you follow now, or what is your target degree of lowering of LDL cholesterol, with the variety of medications we have available now, we can achieve very low levels of LDL.
Yeah, no, I'm glad you say that. Rather than dating either one of us in terms of how long we've been in medicine, I do remember prescribing the bile sequestering agents. I do remember trying to convince people that that cholestyramine bar was not so bad. And now we do have a whole different set of issues that we deal with, which are really exciting. I mean, in most patients, we can really drive down LDL cholesterol and lower their risk. That gets to another question, Pam, which is, how are you thinking about what I'll call lipids in complex patients, meaning things like HIV, chronic kidney disease, diabetes. So where we're really thinking about LDL as being part of the equation, but certainly other contributors to that patient's individual atherosclerotic risk.
I think this is such a challenging, well, these are challenging groups of patients. And if you consider the very low implementation of evidence-based guidelines in straightforward patients with cardiovascular disease, you can only imagine how challenging it is in patients that are being cared for really outside the cardiology world. In rheumatology clinics and infectious disease clinics. In addition, many of the medications that these patients are taking, such as immunosuppressants or the retroviral therapies, have important interactions with lipid-lowering medications. So I'm really excited in this session. We will be diving deeper into the management of these very high-risk patients at increased risk for cardiovascular disease, but with also important considerations for drug interactions and tolerability of the medications.
Yeah, that last piece, I think, is something that clinicians who are listening to the program really want to pay attention to. That's the drug-drug interactions that we want to be really acutely aware of. And I think that this will be an important session for that. Let's move now beyond LDL and get into an area where we have both some excitement, but also a bit of controversy. And that's the issue of triglycerides as a target for lowering, as a way of continuing to improve risk in our patients with atherosclerotic disease, particularly in our patients in whom we already have LDL under control.
So, the one thing that's a little confusing, and I think we have to be careful when we talk about triglycerides, and we want to be careful about whether we're talking about triglycerides as a marker of elevated risk in patients versus specifically just lowering triglycerides to lower triglycerides and possibly therefore have a cardiovascular benefit. It's been challenging to show that agents up to this point exert their benefit by lowering triglycerides. We think back to some of the older trials. Monotherapy with the fibrates may be some benefit, but in the statin area, really difficult to show that lowering triglycerides specifically lowers cardiovascular risk. On the other hand, with the newer prescription icosapent ethyl, and the prescription forms of the carboxylic acid preparations, we've had 2 trials that have looked at what about using triglycerides as a marker of patients who are at increased risk to see if these agents were of cardiovascular benefit. And we did see some benefit with icosapent ethyl, not so much with the carboxylic acid combination preparation. So I think we'll be diving into that a little bit more in depth. I think it's important for our listeners to distinguish the two: triglycerides as a marker of an increase in atherogenic lipoproteins, perhaps in remnant particles, versus just targeting lowering of triglycerides, which may really be more relevant for prevention of pancreatitis.
Yeah, really great pearl to separate out those two and to think about them perhaps not completely differently, but at least think about them as representing separate questions. The final thing, we have about 2 or 3 minutes left, Pam. I want to get your reaction to this. We talk about primary prevention, we talk about secondary prevention, but there's a whole group of patients who seem, at least in my practice, to fall somewhere between the two. Meaning primary prevention is traditionally thought of as people who haven't had an event but are at risk. And secondary prevention, obviously, they've had an event and you're trying to prevent recurrent event. What about this group of patients that are high risk but who have not yet had an event? The ones I think of are people who come to see me who have had a coronary calcium and it's very high, who have had, for whatever reason, CT angiography as part of a chest pain workup. And while they didn't have an acute event, they have high atherosclerotic burden. How do you think about those patients?
We like to call those primary prevention and a half patients. And so it's a little confusing. It reminds me of be careful what you wish for. I remember back in the 90s, we were wishing that we would have an more rapid uptake of the importance of imaging for subclinical atherosclerosis. And we've got that now with the guidelines. So the guidelines now include specific detailed recommendations for when to image for coronary artery calcium. However, we have recommendations for doing it, but the management of those patients, evidence-based management of patients with extensive subclinical disease has really lagged a little bit behind. And so the guidelines don't always inform us about how to manage those patients. Now, it's pretty easy with statins because those are, obviously indicated in primary prevention. It's a little easier with ezetimibe, but it becomes challenging for those high-risk patients who have inadequate lowering of LDL and may need some of the newer non-statin therapies, and we don't yet have FDA approval or guidance for implementation of those therapies. So those patients still remain a bit of a conundrum.
Yeah, I think you've hit upon some of the key issues. I too refer to these often as 1.5 prevention to indicate, just as you did, that they have sometimes characteristics of each. Well, Pam, this has been a really great walk through the kind of topics we're going to hear about in depth on Wednesday, December 8th. So I want to thank you for joining me here on Medscape Cardiology. Again, my guest has been Pam Morris, who is a professor of medicine at MUSC and the director of preventive cardiology there. Pam, thanks for joining us, and we look forward to seeing you in December.
Great. Thank you so much for the chat.